Good morning, everyone. And we are starting. This lecture is the continuation of what we left uh, the previous one. So I think better I should mention this one continuation of previous lecture, right? Continued. So or continuation. Okay. So that you guys can understand. Okay, what's going on. So in the last lecture, what was our last discussion was about iron deficiency anemia, right? And the other, I like because we are studying diagnostics and I'm giving you more like how to approach the things or how to do how to um, interpret the things, So that's the reason I'm going to take you in this way, and our discussion will go in this way that what you will do or what you will see first if you had a blood like any test report in front of you, of course. Uh, so in this one, previously, like we were studying iron deficiency anemia. So in this one, we are going to study vitamin B12 deficiency anemia, right? So as we know, vitamin B12 deficiency, it takes a lot of time to develop, and because body have like stores of vitamin B12, and there is it could be due to intrinsic factor deficiency or pernicious anemia can be there. It could be due to inadequate intake. But the most common reason for deficiency is due to poor absorption. Okay, so you can say the most common uh, reason for deficiency is uh, due to poor absorption. And now, like the reason due to this poor absorption can be anything. For example, uh, any kind of malabsorptive syndromes. So we know like the vitamin B12 is bound to a protein called intrinsic factor, which is secreted by the gastric parietal cells. And yeah, like the vitamin B12, it is combined with the intrinsic factor, and that is needed for the absorption of this thing. And then what happened is like vitamin B12 is absorbed in the um, ileum, ileum, whatever. And one of the factor which can lead to poor absorption is the intrinsic factor deficiency. And whenever it is due to intrinsic factor deficiency, you can say we call it as pernicious anemia. Okay, so pernicious anemia is there. So what is going on in pernicious anemia? There is basically um, defective intrinsic factor production. Okay, so that's the reason like when there is no intrinsic factor, so of course like there will be no absorption, right? So pernicious anemia is autoimmune condition, guys, and this one what happens like there is the formation of auto antibodies which are formed against the gastric parietal cells, and gastric parietal cells are damaged, and gastric parietal cells are those cells which produce intrinsic factor. So uh, now the story, because it is a continuation of what we were discussing previously. So the story goes simply in this way that um, you perform CBC, right? And you found that the hemoglobin is less, right? And all the things which we had discussed in the previous lecture, like, look at the other cell lines, and if the other cell lines are defective or affected, go for bone marrow studies, If the RBCs are only affected, then look for reticulocytosis. If the reticulocytosis is increased, so think about hemorrhage or hemolysis, and the things can be differentiated on history. Uh, if the reticulocytes count has not increased, then think about, then of course, like look at the MCV, and on MCV we can say that either it's megaloblastic, it's macrocytic, it's microcytic, or it's normocytic. So vitamin B12 deficiency anemia, remember it is macrocytic. Basically, it's macrocytic with megaloblastic changes. Uh, what is this thing? Of course, uh, it's hard to discuss like every aspect of anemias here because we are studying diagnostics, of course. But uh, just to tell you uh, superficially, what happens is when the vitamin B12 is deficient, so uh, there is abnormal differentiation of the cells, and they're like the nuclei of the cells, they are also abnormally, you can say, produced, and we can see those changes by microscope. So we call those changes megaloblastic changes, right? So whenever the people have macrocytic anemia, we see either it is with megaloblastic changes or without megaloblastic changes. So whenever it is with megaloblastic changes, the cause can be vitamin B12 or folate deficiency. So now, see what makes sense, by the way, in this case is if you found that someone have increased MCV or it is macrocytosis is there, then what is the test we must do? We are going to write for or do vitamin B12 levels, okay? And of course, when they come as reduced, so we make the diagnosis of a vitamin B12 deficiency anemia. And one of the cause, which is pernicious anemia, of course, you can go further studies for autoantibodies. But uh, to tell you, there is a very interesting type of test which we can do for these patients that is called as um, Schilling Schilling test. Okay. Uh, by the way, nowadays this test is not done much because we have like new things. But for medical students, this test is very important to understand. I will found if we can found any good photograph like so that I can explain you what is Schilling test. Okay. Otherwise, of course, like I'm going to write down over here. Okay. So okay. Schilling test. Okay. Maybe I think I found something. Okay. Uh, okay. Leave the things what are written. Okay, because I think it's like the other language. Some other language is written. Okay. So to tell you, like to start with, what this test is used for. So simply, uh, it is used to distinguish um, between, you can say, various causes of vitamin B12 deficiency, right? So this test is used for various causes of vitamin B12 deficiency. Now, to tell you, for example, vitamin B12 deficiency can be caused due to inadequate diet, number one. Number second, vitamin B12 deficiency can be done due to intrinsic factor deficiency. Number third, vitamin B12 deficiency can be caused due to other malabsorptive syndromes like celiac disease, in which the intestines cannot absorb this vitamin, right? And number fourth, vitamin B12 deficiency can be caused due to bacterial overgrowth in the GIT. Okay. Now, uh, what they do, See, first of all, we give them one dose of intramuscular vitamin B12. Okay, we give them one dose of intramuscular vitamin B12. So when we give them intramuscular vitamin B12 dose, this dose is basically given to, you can say, saturate the body stores of vitamin B12. Okay, so that you have enough vitamin B12 in the body. So the first step is this one. Second step, we give them one dose of vitamin B12 orally, and this dose is radio labeled. Uh, what is radio labeled? This is simply vitamin B12, but they label it with some radioactive thing, simply, uh, which we can catch. Like, see, we are giving non-radio labeled vitamin B12 by intramuscular injection to saturate the body stores, and we are giving radio labeled vitamin B12 by orally. Okay, this dose is also called as flushing dose. Okay, so now, practically speaking, when someone is taking this dose and vitamin B12 is going, attaching with the intrinsic factor and getting absorbed through the ileum in the blood circulation, when it is already saturated with other injection of vitamin B12, what will happen? That the extra vitamin B12 is going to appear in the urine. So what it means, all the radio labeled vitamin B12 which we will give orally should appear in the urine if the intrinsic factor is there, if the absorption is normal. Okay, so normally when a proportion of the oral vitamin B12 dose will be absorbed and excreted, okay, so you can say more than 10% of the oral dose should be excreted in the urine. But what will happen if there is some malabsorption of vitamin B12? So now this vitamin B12 which is given orally cannot be absorbed in the blood. So this will be wasted in the feces, or simply will not appear in the urine. Okay. So with vitamin B12 malabsorption, this amount will be reduced. So uh, now, if this is the case, like we get the radio level vitamin B12 in the urine, okay, everything is fine. But if we are not getting, we again give one more radio labeled dose with intrinsic factor. So after giving with intrinsic factor, if the dose started appearing here in the urine, it means there is deficient intrinsic factor. Even if after giving intrinsic factor it is not appearing here, it means like there could be two reasons. Number one, there could be malabsorption. Number second, there could be bacterial overgrowth. So we can give the third dose with antibiotics. So when we give the third dose with antibiotics, so the antibiotics kill all the bacteria here, we see either the vitamin B12 is appearing or not. Okay. So simply one possible cause of ileal disease can be bacterial overgrowth. So in that case, we give the patient antibiotics and we see either the vitamin B12 is appearing in the urine or not. So this is what we do, right? One more way of diagnosing bacterial overgrowth is also there. that is called as breath test or hydrogen breath test. We give carbohydrate load to the patient orally, and the bacteria in the small intestine will metabolize the carbohydrate. Then they are going to release the hydrogen, which can be absorbed and can be detected in the exhaled air. So that is what you can say another way of diagnosing, if like checking if they have bacterial overgrowth, right? So simply, number one step is give IM, vitamin B12, give radio labeled uh, vitamin B12 orally, measure the vitamin B12, of course, like radio labeled, in urine. If not detectable, add intrinsic factor with radio labeled vitamin B12, right? Okay. If still not there, give antibiotic course, or you can, or um, hydrogen breath test can be used to detect uh, bacterial overgrowth. Okay, so like this is the basis for these tests, and easy to understand, not hard, guys. Okay, unfortunately, like the same thing shown in like the slide form, right? Of course. But I don't think so. Like there is some good photograph. Like by the way, it's hard to make a photograph to explain all these things. Okay. So again, like you can see over here, the same procedures explained over here. So this is called as Schilling test, right? So uh, Schilling test can tell you either there is intrinsic factor deficiency, either there is malabsorption, either there was bacterial overgrowth. But nowadays, guys, this test is not used much. Why? Because we have many more testings. Okay. So see, you get macrocytic anemia. You think of vitamin B12 levels. You did that. You can do Schilling test. For example, if okay, the other case can be vitamin B12 levels come back as normal. Then what is the next best investigation? Now remember, I already told you what are the causes of macrocytic anemia, and as this lecture is a continuation of that, go for folate analysis. Why? Because folate analysis is simple, and you can say serum folate levels can be measured, and if the levels are low, we can diagnose the patient with folate deficiency anemia or folic acid deficiency anemia. Folic acid deficiency can be due to diet, can be due to certain medications. So there are a number of reasons of folate deficiency as well. Okay, so simply, by the way, I can include this thing over here. Okay. Now, uh, the next thing, okay, rest, guys. Um, before going further, maybe you will start thinking why I'm not talking about alcohol, uh, why I'm not talking about drugs, why I'm not talking about hypothyroidism, which are the causes of macrocytic anemia, right? But remember, all these things are diagnosed on history or clinical examination. And you can do, for example, thyroid function test as investigation to confirm hypothyroidism. But keep this thing in mind that all these things, for example, alcohol and all these things can be diagnosed clinically on history. Okay, so on history, if someone is taking, for example, a drug called as methotrexate, or for example, someone is having hypothyroidism, so you will go for TFT. So that's why I'm not discussing for all these things. So uh, we have discussed, simply we have discussed microcytic as well as macrocytic anemias, right? And now what is left is normocytic anemia. So uh, normocytic anemia, two very important causes. Remember, one is hemolysis and one is hemorrhage. One is anemia of the chronic disease. Now, let's talk about hemolysis because that's something interesting. Okay, so and that's important as well. Okay, hemorrhage, again, that will be diagnosed on history, right? You will ask the patient if they have any bleeding, or for example, if the bleeding is very, very, very slow, then it present as iron deficiency anemia because there is less like slow blood loss from in the stools, for example, in old people who have cancers. So they present with iron deficiency anemia, not with this thing. So I'm going to discuss hemolytic anemia. Okay, and what is hemolytic anemia? Simply, it is hemolysis. Okay, uh, and simply we can define hemolysis as um, you can say destruction or abnormal destruction. Okay, abnormal destruction. Why abnormal? Why I'm using the word abnormal destruction? Because remember, when the RBCs, they have completed their life cycle, so they are destroyed anyways. So of course we will call it as hemolytic anemia when the destruction which is going on is abnormal, okay, or at huge rate, or uh, at more rate what is considered as normal. So of course then it will be called as hemolytic anemia. So now um, some of the clinical things I will tell you. When the red blood cells are destroyed, okay, in the body, what happens? Hemoglobin is degraded, and again, uh, I will take here the help of Bing to show you guys. Uh, this is my way of teaching in the classrooms as well. I just open on the projector, Bing, and I show you, like, instead of making slides, I show the things online. Okay, selecting the best one right at that time. So, for example, what we can write here as bilirubin, for example, images. Okay, so yes, a very good diagram. When the red blood cells are destroyed, the hemoglobin is degraded. It is degraded into globin, which is the protein part, and the heme. Okay, so the heme is further degraded to iron and bilirubin, right? So when the RBCs are going to destroy at more rate, what will happen? That this thing will be produced more. And as you know, the unconjugated bilirubin, it is taken to the liver, and then the liver conjugate it by the help of the enzyme glucouronyl transferase, right? So, uh, and then the conjugated bilirubin, which is the water soluble, enter into the enterohepatic circulation and released in the urine in the form of urobilinogen, or in the stools in the form of urobilinogen or stercobilinogen or stercobilin, right? So simply, um, What are the important points to understand here? Bilirubin is conjugated into the liver, passed into the bowel in the bile. It is converted into urobilinogen. Some of that is passed in the stool. Some is reabsorbed. See, reabsorption is there and excreted in the urine. Okay, and we can detect this urine by the help of urine dipstick test. Okay, or urine analysis strip, you can say. So in case of hemolysis, more and more bilirubin will be formed. I think makes sense, right? When more and more bilirubin will be formed, so more and more unconjugated bilirubin will be there. Remember, the unconjugated bilirubin, which is water insoluble, it is bounded with albumin. And of course, albumin is limited. So whatever will be extra is going to circulate in the blood. Whatever it will be taken to the liver will be conjugated. But of course, liver has some capacity to conjugate. So the plasma unconjugated bilirubin simply rise, and the increased amount of urobilinogen can also be detected in the urine, as well as the levels of lactate dehydrogenase is going to raise as well. Okay, so now the important thing over here, maybe like in many of you, you were thinking, for example, what is lactate dehydrogenase? Okay, so guys, lactate dehydrogenase is basically LDH. We write it as LDH, and it's an enzyme which is found in almost all the cells. Okay, and lactate dehydrogenase, which is the name of the enzyme, which is present in every cell, it is the one which converts the lactate to pyruvate. Okay, so now uh, when the RBCs, they are going to destroy at high rate, what will happen? There is more and more LDH will be released in the blood. Okay, and when more and more LDH will be released in the blood, we can measure it in the blood simply, which can be a marker of increased RBCs destruction. By the way, this LDH have different isozymes: LDH1, LDH2, LDH3, LDH4, LDH5. Okay, and LDH1 is basically present in the RBCs. Okay, LDH1 is present in the RBCs, but no need to remember that. Only thing to remember is the LDH can be raised in hemolysis. So now the important thing over here, when the red blood cells are destroyed inside the blood, remember the blood is inside the running into the intravascular space. Okay, so hemoglobin is released when the RBCs are destroyed. Okay, so again I will show you this one. So this hemoglobin which is released, uh, like much of that is degraded and much of that is freely revolving in the blood. So there is something called as haptoglobin. Okay, there's something called as, so one story is about LDH, right, and one story I'm telling about haptoglobins. So haptoglobins basically bind to free hemoglobin. It binds to free hemoglobin, and you can say escort this to the liver. Okay, now the important point here to remember is that haptoglobins are also limited, and they can get saturated as well. If the hemoglobin is too much, so haptoglobin can get saturated, and when the haptoglobins will get saturated, what will happen? That the hemoglobin will keep on circulating in the blood, and it can be passed in the urine, will lead to hemoglobin urea. Okay, so what is this? When hemoglobin is present in the urine, or it can be converted into hemosiderin. Okay, hemosiderin, and which can again then pass into urine, will lead to what? Again, hemosiderin urea. Okay, so these things we can detect in the urine as well, right? So simply now what is our final findings? Okay, you can say uh, labs in hemolysis or hemolytic lytic anemia. Okay, what will be the result of labs? Number one, you are going to check the hb. Hb will be low. You are going to test for reticulocytes. Okay, it could be raised. More and more RBCs will be formed. You will check for um, okay, bilirubin can be raised. Okay, bilirubin, I'm writing bilirubin in general. Okay, can be raised. Okay, but bilirubin can be raised in many other conditions, right? So we need something specific. So haptoglobins, what will happen to them? Haptoglobins will be what? Reduced or raised? Of course, reduced, because they are attached with the hemoglobin. What will happen to the urine? Oh, sorry, what will happen to LDH first of all? Raised. Okay. What will happen? Like, what will the picture of the urine? Though we are not discussing urine right now, but we will found hemosiderin urea as well as hemoglobin urea. Okay, so we are finding this thing. So of course, like with excessive red blood cell destruction, the bone marrow works hard to replace the number of circulating cells, and reticulocytes will be formed in the circulation, so therefore it is going to increase. Okay, now the next discussion is what? These all tests will just tell us either there is hemolysis going on or not. So when you did this test and you found that, okay, there is hemolysis going on, what to do next now? Next step is to what? Find the cause of hemolysis, right? And to talk about this one, what are the tests to find out the cause of hemolysis? What is the important thing, guys? The important thing is, first of all, you must know what are the causes of hemolytic anemia. If you don't know the causes of hemolytic anemia, uh, how you can diagnose or the causes of hemolytic anemia? Okay, how you can do the test to diagnose hemolytic anemia? So now we will talk about hemolytic anemia classification. Okay, what is the causes of hemolytic anemia? So now remember one thing, that whenever someone have hemolytic anemia, it could be acquired, it could be congenital, or inherited. Okay, inherited means like someone took it from in the genes or on birth. Okay, acquired form. Now, whenever it is acquired, the destruction can be immune related or immune mediated, like the immunity is playing role in destroying the RBCs, and it could be non immune mediated, in which immunity is not playing role. Okay, and whenever it is inherited, again there could be few of the causes. Number one could be uh, abnormal red cell membrane. So see, because like the RBCs have, because inherited causes, of course, either it is some gene defects or either there is some enzyme defects, which is secondary to gene defects, of course, and that's the reason like the cells are not formed normally. So it could be abnormal red blood cell membrane, it could be abnormal hemoglobin, it could be abnormal, you can say, uh, red cell metabolism. Okay. So, and by the way, on all the books, this is written in the same way. And how I remember like this thing, because just now I did a pediatrics lecture on this thing, like what are the causes of inherited. So see, when there is some deficiency in the red blood cell membrane or abnormality, of course, it cannot sustain itself. The red blood cells are going to destroy, or they could be of abnormal shape. Whenever there is defective hemoglobin, for example, thalassemia is an example of that. Anyhow, I will quickly tell you. See, immune mediated destruction. What can be the causes? So there could be number of causes of immune mediated destruction. It could be uh, autoimmune, okay, which is further divided into the warm type and cold type. Of course, we are not going to discuss that here. It could be a transfusion reaction. If you are going to give blood group A person a blood group B blood, so of course, like they will be having this thing. It could be hemolytic disease of newborn, HDNB. What is this one like? When the baby have miscompatibility, or the mother have the different blood group and the baby have different blood group, like the negative positive. So, and it is like the second baby. So again, like we will discuss it someday. And it could be due to drugs, like the drugs which is causing hemolysis. When it is non-immune mediated, guys, there are certain infections which can cause this thing. Malaria can cause. Okay. Then there is something called as hemolytic uremic syndrome. In that one, there is hemolysis, which is non-immune mediated. It could be hypersplenism, hypersplenism, in which the spleen is destroying more and more RBCs. It could be mechanical heart valves. The people who have metallic heart valves in the heart, uh, when the RBCs are going to hit those metallic walls, they are going to be destroyed. It could be paroxysmal, nocturnal uh, hemoglobinuria. Like these are the people who have hemoglobin presence in the urine whenever they are under some stressful condition. It could be due to burns. Okay, so these are the causes of non-immune mediated, and these are the causes of immune mediated, right? And if we will go on abnormal red cell membrane, there is a test. There is a anemia called as phagocytosis. So uh, uh, phagocytosis. So normally, like the RBC shape is biconcave, right? So there is some membrane abnormality in which the cells are like balls. So remember, a biconcave shape of RBCs are good because like they can be squeezed while passing through the capillaries, and they can pass easily through capillaries, whereas the spheres they cannot sustain that and they get burst, okay, and that's why it will lead to hemolytic anemia. Or the RBC shape could be like elliptocytes. So if you know what is space shape, you know what is elliptocytes, right? Or elliptocytosis, like there is more cells which are looks like ellipse. Abnormal hemoglobin, guys, a very common example is thalassemia. Okay, of course, very very common. Or sickle cell disease, very common in Mediterranean people. Okay, and whenever it comes to the red blood cell metabolism problem, so a very common enzyme and a very important condition called as G6PD, uh, which is G6PD. And if you have done your biochemistry in a good detail, G6PD enzyme is basically glucose 6 phosphate dehydrogenase enzyme. So, many people they have deficiency of this enzyme, and whenever they are in stressful condition, their RBCs get broken down more and more and more. Or there could be PK deficiency or pyruvate kinase deficiency. Again, I'm telling you, if you have done your biochemistry in good details, you must know what I'm talking about. And if you don't know what I'm talking about, guys, open biochemistry books, search PK, read about that, search G6PD, read about that. It is very, very, very well explained in Lippincott of biochemistry, and of course, like in every book, but because like I know that book, so that's why I'm taking the name of that book. So now, guys, like the important thing here is what? Okay, the important thing here to understand is what? There are many conditions. To diagnose them, we have to do different testing. For example, malaria will be diagnosed on thick and thin films. Different diagnostic tests are for this one. Mechanical heart valve will be more like history. Okay, burns will be more like history. Drugs will be mostly more like history. Okay, transfusion reaction, you would, if you know the history, you can catch, right? So most of the things, we can diagnose on history, but what we cannot diagnose on history, for example, spherocytosis, okay, there is a test called as what you can say, osmotic fragility test. Okay, now as I told you, again I can show you um, hereditary spherocytosis. You can see in hereditary spherocytosis, their cells are completely round in shape, right? And normally the RBCs are biconcave in shape like this, but see spherocytes like the RBCs are mostly almost round in shape. So we do a test called as osmotic fragility test. Okay, so uh, wait, yes, this one. So see, uh, whenever we put the RBCs into isotonic solutions, right? Like biconcave RBCs, what will happen? Isotonic solution in this one, and this one. So, what happens in this test is, like, of course, the red blood cell membrane is abnormal, in which the cells become sphere in shape. So, the cells, they are not so resilient, you can say, or the cells are less resilient to damage. Okay, so even a small stress can kill the cell or can burst the cell is going to burst open. Okay, so uh, simply they put us that blood in some solution, like this one, what they are showing you. Oh, sorry, I closed that. Like they want to show you, like, if we will put a normal RBC in an isotonic solution, so what happens? The RBCs can sustain that because the water will go inside, and the water can make the normal RBC more like a sphere. But whenever the cell is already a sphere, it can burst open by putting it into isotonic solution. Okay, so that is called as osmotic fragility test. Other than this osmotic fragility test, guys, one of the tests we can do, especially to diagnose autoimmune mediated conditions, is, if you don't know, just go and read about that thing. It is one of the very very important tests which you should know. That is called as Coombs test. Okay, and it is also called as direct anti-globin globulin globulin test. Okay, so this is very 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 important test. So whenever the anemia is due to or whenever the anemia is autoimmune anemia, uh, like of course the antibodies are there which attack the RBCs and cause their destruction. So okay, so this test basically detect the antibodies. Okay, so uh, it could be called as Coombs test, it could be direct antiglobulin test, or it could be written as DAT, direct antiglobulin test, right? A short form of antiglobulin. So in this test, like, antibodies to human immunoglobulins are added to a sample of red blood cells. Okay, so what we do, we add antibodies to human immunoglobulins. Again, if you are good in immunology, you must understand what I'm saying. We add them to a sample of red blood cells. Okay, so from the patient, of course. Okay. So uh, now, um, if the red blood cells are coated in antibodies, okay, like for example, if the patient have autoimmune anemia, okay. So what is autoimmune? Of course, like antibodies are there, right? So in autoimmune, what is there? The you will like the patient RBCs are coated with what? Antibodies. Okay. So when we um, what you can say, when we are going to add the antibodies uh, in them, okay, so what will happen? They are going to agglutinate. Okay. So simply you can say, if the patient uh, has an uh, autoimmune hemolytic anemia, what will happen? They will agglutinate. Okay. So now guys, this concept is very important, by the way. Again, like I could show you this thing as well, because this is worth understanding, like Coombs test. Okay, there are two tests, by the way. One is called as direct Coombs test, and one is called as indirect Coombs test. Okay, so um, yes, see this one. Direct Coombs test is there. Uh, we can take the patient sample. Okay, uh, see the RBCs are there. Plus, we are going to put anti-HU IgG Coombs reagent in them. So what will happen if, of course, like the blood RBCs have antibodies on them? See, there is agglutination. They are all attached together. Okay. So there are like I've seen photographs here which are explaining both direct as well as indirect tests. So sorry, this is again some other language. I don't know what's going on. Maybe it's due to bad VPN. Okay, guys, wait. Wait. I'm going to switch it to English. Okay, and then I'm going to yes. But again, I'm sorry. Like, yeah, this one. So you can see this one. This is the direct Coombs test or direct antiglobulin test. They take the blood from the patient, they put it in the test tube, and later what they did, they uh, put a Coombs uh, reagent, like having the immunoglobulin. So if the RBCs have antigens, what will happen? They will agglutinate. Okay, they are going to agglutinate. So it shows like the patient have uh, autoimmune mediated anemia, and this is okay. But as we are studying diagnostics, so it's okay. We can, because we are not discussing right now here. Indirect Coombs test is used. You can see over here, uh, like they take the serum from the recipient, okay, which contains the antibodies IgGs, okay, and then they take the donor blood sample, they add it into this one, and what is there? See, now the immunoglobulins are like the antigens are attached over here, antibodies are attached over here. So what happens is, like they put the Coombs reagent, and if they agglutinate, so uh, because like again the immunoglobulins are going to attach to them. So like these are the tests which we can use to find out like what is the cause of anemia. One catches the circulating and one catches the fixed antibodies. Okay, so again I'm telling you, if you don't know uh, about this test, this is very important. By the way, it's very basic thing to know. So I hope like uh, you will go and check what I told you. So thank you so much, guys, and of course, like we are have to discuss more and more hematology, but we will continue in the next lecture. Thank you.